Okay, everyone, we're about to get started. 30 minutes, one question, one follow-up. I'll turn it over to Dr. Williams and Dr. Yaffe for brief remarks.
Hi, good afternoon. And so here we are on, I call it our next 2-week period. It's the 8th one, actually, and looking at this coming 2 weeks of how we are doing with our physical distancing. The impact of that further from what you heard yesterday. It was people digesting the modeling data and information, the potential impacts of what it could mean, the impact of what it means if we undertake to be even more vigilant and diligent in our spacing. I noticed when I was coming in, there's still quite a lot of people out on the streets. I think they're trying to keep distancing. It's challenging, I would say. And so we've asked people to try and do it at different hours and not all at the same time if you have to go out. Otherwise, stay home and limit your movement unless you can guarantee your physical distancing of the 2 meters. So, as I said yesterday, we had those numbers out. We've seen that we've had impact as Ontarians collectively. We've bent the curve to some extent. We'd like to bend it even further. And so then we have to make sure we're watching this coming week, because this is the end of the week where we had the 2 weeks back. We're seeing the lab results of a lot of the people who had traveled and returned. As Dr. Yaffe gave some data, still 20% had some travel history. And that should be waning off as that had closed down by the 20th to 25th or so of March in that time period there. So we have a little bit of overlap this weekend, early into next week, and now we want to see how well we are doing in that regard and perhaps demonstrate even further success with our attempts to flatten the curve, if you may. So let's go over to the detailed numbers from yesterday with Dr. Yaffe.
Thank you. So as of yesterday at 4 p.m., the data in the Integrated Public Health Information System, IFIS, that public health units enter data into, we have a total of 3,630 confirmed cases of COVID-19 in Ontario. This represents an increase of 375 additional cases from the previous report. Almost 33% of the cases are 60 years of age and older, and about 52% of cases are people who reside in the Greater Toronto Area. Of all the cases, 21% have traveled in the 14 days prior to becoming ill, and again, this is going down, hopefully. 12.5% had close contact with a confirmed case, and 18% were spread through the community. We still have about 48% where the exposure information is still pending, and hopefully as we provide more resources and more staff to the health units to supplement their work in case and contact follow-up, that percentage will go down, so we'll have more information on that. There are currently 94 lab-confirmed cases who have unfortunately passed away. And we're aware of at least 36 outbreaks in long-term care facilities, with 54 deaths related to those outbreaks, some of which are lab-confirmed and others are epidemiologically linked. We continue to see the number of resolved cases increase. We're now at 1,219 resolved cases. Currently, we have 506 cases in hospital. Of those, 196 are in intensive care unit, and 152 of those are on a ventilator. Lab testing, at this point in Ontario, we've tested 72,674 people. We only have 1,336 that are pending now, and in the last 24 hours, we've processed over 5,000. Our capacity at this point actually is about 9,400. With that, I'll turn it back to Dr. Williams. Thank you.
Okay, well, thank you. And it was good to note in there that pretty well a third of our cases have resolved. And so that is good news, and I think we're going to continue to see that number rise as we go through the main phase of when we had increased all those numbers, and they have are finishing their 14-day quarantine period. And so that is encouraging in that light there. It's interesting to note, as I said, we still have about the 20% or so that had travel history in that data there. Some have the contact history. The majority, of course, right now, and that's what Dr. Yaffe is alluding to with the desire to really enhance the case contact resources in the public health units, that we have still about 50% that don't have the full data in there. So that's a challenge for us. And then we hope to see as the week goes on, the travel ones will drop down even more and more as the travel options were eliminated back 2 weeks ago, heading into the week and a half ago. So we'll see how that result goes there. Still, you see most of our cases tend to be in the age group of basically 20 to under 60 in the ones that were presenting themselves to us at our various assessment sites. And we have nearly 100 now operating in the province in that regard. And the lab test there, that number you see pending, is what usually flows into the labs anyways as part of their normal operations. So as far as we're concerned, we don't have any outstanding ones. They're just in the queue for being processed in that 24-hour period. And again, seeking to prioritize those that we've already identified before, and to make sure that those that need them get them back in a very timely fashion that'll help to make decisions on either work situation or with activities around outbreak management. Still, of course, our concerns is that the global situation continues to escalate in many different settings, and there's some new settings we're watching very nervously in some other areas, how that might impact in there. We see the U.S. numbers, of course, continue to rise, heading up to over 275,000 cases at this time. So with that, I'm going to open up for questions and hand things over.
We'll take the first question.
First question comes from Kari Verma from CBC National News. Please go ahead.
Hi there. The Premier said Ontario is waiting too long for things like mask manufacturers and ventilator manufacturers to get the green light to start manufacturing domestically here in Ontario. Can you provide any specifics on what we're waiting for from Health Canada, and do you share the Premier's frustrations and concerns? And also, are you guys concerned at all about not getting PPE from the United States given the executive order?
Okay, 2 or 3 questions there. First, on the aspect of the normal processes when you have newly manufactured equipment and materials, be it ventilators and or personal protective equipment, it goes through a certain level of assessment and I would say paperwork to get the approval of the authorizing authorities such as Health Canada. I think what the Premier was talking about is that if we're producing these products in Ontario and we're satisfied by the manufacturer, it meets all the requirements, to go through a long drawn-out approval process during this time of urgency, is that really necessary? So I think the Premier's asking for, including all we're trying to do these days, that those processes would be handled expeditiously so that we would not be held up in that regard. As far as the impact on the ruling with the U.S. government in that regard, I see there's ongoing discussions. So we're optimistic that things will still be carried out in a proper way between I guess major trading partners, because there's flows of materials still from Canada going to the U.S., I understand, that are useful also for them to undertake there. So in one sense, we're sort of in this together, but we want to make sure we respect each other in that way. And I think the Premier has said he was going to deal with that, well, not only with the Prime Minister, but perhaps with people across the border. So I'm going to leave that really with our federal authorities and with our Premier to handle in those regards. So everything on board to get the best what we need for our workers.
Follow-up?
Excuse me.
And just on the question of long-term care facilities, when was the first directive about how to manage a COVID outbreak sent to long-term care facilities? Did ministry officials tell them to separate the sick from the unsick at the very beginning? And if you can provide some details on what is the current directive to long-term care facilities on how to manage when they have a suspected COVID patient?
Okay. Well, our first one was always the one historically there, is to remind them of the outbreak management that we have existing in our protocols under Ontario Public Health Standards. In that, and with the agreed upon infection prevention control practices that have been put out at length over the years with the Provincial Infectious Disease Advisory Committee and from Public Health Ontario. So those had already been in place. They were ratified right from the get-go to everybody to check all your resources, make sure you're prepared to do that, and you have all your communications up and running, et cetera, et cetera. Then when we were concerned that the sensitivity was not, I would say, stringent enough, could we change those from our regular outbreak management to a more sensitive one where you may not have an outbreak at all, but if you think you have a case that has some evidence of COVID, which is like any other upper respiratory infection, fever, shortness of breath, cough, that you would not wait to see if you get your second one in the organization or in proximity to that person. You declare an outbreak. You start taking steps already. You start doing some wider testing in there. That came out about middle of last week, earlier. And so now they're going through that process of ramping that up. We had a webinar on Wednesday. So I think the directive was out on Monday. So we had the webinar Wednesday, which was to train all the long-term care staff on the new aspects of the directive, which is unique just for COVID itself. And as I said last week, or early this week, I guess we're not finished the week yet, I expect the number of outbreaks to go up, and they have, because they're on a very quick response rate to kick into gear their outbreak management, do the wider testing, and I'm quite prepared to have a number that would be an outbreak declared on one day and then 2 or 3 days later saying, oh, it wasn't, it was another case of something else. But that's fine. As I said before, I can live with false alarms because we've changed that format. So that was, I think the directive on that one came out earlier in the week, Sunday or Monday, and then we did a webinar on Wednesday.
Next question.
The next question comes from Morgan Campbell from Global Toronto. Please go ahead.
Hi, doctors. Can you outline some of the preventative measures that are being taken at this point to prevent the spread of COVID-19 in long-term care homes? And we're hearing reports that some long-term care homes are accepting hospital patients. Can you comment on that? And would those hospital patients be segregated?
Maybe
You go ahead.
I can start.
Yep.
There are many measures that have been put in place based on what we do normally with outbreaks, plus the additional directions in the recent directive. So, starting with your last question, there are instances where a patient in hospital can be transferred to a long-term care facility. If their condition is considered stable, they would have to pass the screening, no fever, no symptoms suggestive of COVID-19, and they would be put in a 14-day quarantine within the long-term care facility, just to make sure that they don't, in fact, have it. The measures in general, there's twice daily screening of every staff person, every resident, including fever, temperature screening, very strict infection prevention and control, scrupulous cleaning, cohorting, what we call cohorting of staff, so that as much as possible the same staff are dealing with the same residents, and we're not mixing as much, and the employer working with the staff to ideally have the staff working only at one facility, minimize the number of facilities they work at. And of course, very keen surveillance, looking for anybody who has any symptoms, even suggestive, sniffles, anything, and getting them tested. And as Dr. Williams said, one case we call now an outbreak, and then testing everybody else around them who's symptomatic to identify what's going on and try and prevent its spread as much as possible.
Follow-up?
Global News has obtained documentation that's directing long-term care homes to keep patients exhibiting symptoms of COVID-19 in the facility and not transporting them to hospital. Can you confirm that long-term care patients are being blocked from going to hospital? And if so, why are we not doing everything possible to help seniors, our most vulnerable?
So let's be clear, there's no directive that tells the long-term, that hasn't changed at all, how long-term care facilities, transfer patients to hospital, and the transfer back has not been altered. More intensive screening in both ways to make sure in that regard. So if there is, for example, a regular transfer from a long-term care facility that doesn't have an outbreak where someone has had some deterioration and the physician who is monitoring that facility wants them to go for procedures, investigation, that still is done. And as always, they want to make sure that they have the documentation so there's no outbreak going on in that long-term care facility and the person is no more symptomatic than what their condition relies upon, so it's no evidence of a COVID infection. If there is an outbreak, then that person would have to be handled in a responsible way such that there was a potential COVID infection as well in that regard. So there's been no directive not to transfer in that. There's just been some heightened concern if it's from an outbreak facility into the hospital. They would have to treat it accordingly, and that's what the emergency departments and the other centers at the hospitals do because they're getting new cases coming in through their emergency department anyways, admitted into their isolation rooms and being handled accordingly. So there's been no directive in that regard. I think sometimes there's some confusion that if there's someone who is already in the final stages of life and that has already had some documentation that they do not want to have certain things done, that's what's done anytime, and that's the decision of the presiding physician as well as the family and other members in that regard. So it's business as usual in the long-term care facilities, of course with the added knowledge of outbreaks of COVID and how one wants to handle that. So no, there's been no directive that stops them from being transferred if it's necessary and if that's the direction of the overseeing physician and facility, and of course the coordination with the acute care hospital where the transfer is going to be taking place too.
Next question.
The next question comes from Mo Sahim from Vista Radio. Please go ahead.
Hi, thank you, doctors. My question is regarding, the Minister of Health, Patty Ajuk, mentioned that medical students that are close to graduating are being accelerated, as well as retired healthcare workers are being asked to come back. How is the province going about that?
So that's where we've looked at our resources and the human health resources to deal with the surge in demand and need. And we've been very pleased that the medical students want to step up to that task in there. We'd want to use them, of course, in an appropriate way that wouldn't put them in any compromised situation as far as their ongoing training and what not beyond their scope of practice of what they're allowed to do with proper supervision in that regard, including lots of other volunteers. We've had some being offered by federal authorities as well. And so our task is then, how would you, one, document that you're using these individuals, second, give them the training they need for their specific task, make sure the task is appropriate to their level of knowledge and capability, and so that you can use then your existing staff who are maybe qualified for various criteria and scope of practice to do that kind of task, because a lot of the work now is very much calling, communicating, coordinating, gathering information, entering that into databases, etc., which is laborious but critical and essential as we're doing our case contact management, at least in the public health sector in that regard. But still we want to be attentive to make sure that the right people are doing the right thing in the right way with adequate coverage, training, and protection if they're going to be involved in any exposure to COVID or potential COVID-19 patients.
Follow up?
And on the vaccine front, there are reports circulating that we're looking at a 2-year wait period as opposed to the 4 to 6 months wait period that you mentioned earlier. Would you mind commenting on that?
Well, I can comment in general. I mean, there are lots of different reports. There's lots of different people across the world trying to develop vaccines for this, which of course will be really valuable once we get them, once they've been tested to be safe and effective. Usually a vaccine, I would say, takes at least 18 months. Anything less than that is being extremely optimistic. So I think 18 months to 2 years is not a wild assumption in this case. But we're keeping up to date, obviously, with what's happening, and remain hopeful.
Okay, thank you. I think we're all done. Next question.
Next question comes from Scott Lightfoot from CTV News. Please go ahead.
There's a lot of focus on the numbers, especially after yesterday. I'm just wondering what you're reading from the numbers involving hospitalization and ICU beds. Is this where you were hoping the province would be at this point? Do you feel that we're approaching crisis levels, or are you happy with where the numbers are compared to what you've seen elsewhere?
Well, where the numbers are, I mean, we gave the facts and the data to the modelers, and they put us on the curve and use that for projecting. So what we have achieved is they noted before that if we hadn't carried out what we had undertaken in the first 2 to 3 months of this current issue here when we started the end of January, we would have been a lot worse off. And that was the reassuring side of it. I think in that way that's the good news. Would I like the numbers even lower? Of course I would. But I have to be realistic with all the different variables and things that are impacting us as we were dealing with that, with large inflow of various movement from other epicenters around the world, be it from Wuhan or from Italy, Europe, and Iran initially, and now a lot returning from the United States and other parts of Europe and other countries where it was deemed not to be an issue. And obviously by our data and information from traveling, it was an issue. And so that large influx of these groups, I'm not talking about a few hundred, I'm talking about hundreds of thousands coming in and back and forth. So we've had to deal with that, and I think that's one of the success stories of how we've handled it thus far. We're in that phase, as I said, as we go into with the traveling diminishing and the border security being improved upon that regard. So we hope to see it go even lower, as the Doctors Brown and Donnelly had said. If we continue and ramp up our integrity and our vigilance, we can drop it even further. The fact that our cases, the percentage is pretty well on par with others as far as positivity, and then how many get in hospital, the 6%, how many go on to ICU, around the 2 to 3%, and the mortality in the age groups seems to be consistent with other settings. So I think in that sense, the whole thing really depends on how many cases we're ramping up on, how many positive cases, because it seems to have very much a prediction how it's going to impact our ICU and our vents in there. And as you're seeing the numbers rising, because our numbers of positive cases were rising, because our number of travelers returning, coming back in that peak time, we're going through that phase. We want to see then, if we can get our numbers back down again, we would see then, I believe, a continual drop a bit further in that. If we don't get our numbers down, if they go up for other reasons, people are not vigilant, not handling the distancing and that kind of aspect, then we will have to deal with the increased hospitalizations and ventilators, as the modelers said would occur. So it's a double message, and yet it is very stark, and it's revealing that this is a serious matter. We have to do what we need to do, and we know how to do it. We just have to do it again, do it well, and do it every day. And be conscious of that all the time and not be forgetful.
Follow up?
And you mentioned that you're sort of looking at this in benchmarks. I think you used 2-week examples. But as we get to the sort of 2 weeks from when travel was shut down, are you expecting to see the number of travel-related cases go down? Are you expecting to see the number of new cases go down? And will that perhaps provide a false sense of optimism for people who think, oh, things are getting better, we can get back to normal right away?
Good question. And that's why I was saying the impact of the heavy travel time is going to start to get out of that incubation period over this weekend into early next week. And then as I said, then the rest of that week and the week after is how well are our public health measures working? How well are we doing with our physical distancing? Because it's in that control. If we're not being exposed, if you're not getting it from anybody, it's not growing, it's not spreading, and our numbers should diminish. If it doesn't, that may tell us that our measures are not heartily enough, and we're not handling that. So I would say after that, if we see our numbers come down a little bit in that sense there, that would give us some encouragement. I would say, as I said before, when we were ratcheting up our public health measures appropriately, if and when we see some signs, then we have our public health measures table, which is a special group meeting, and to discuss that aspect to say, what should you roll back a bit when? Because you roll back too soon. We did that in SARS. We found a second wave rebound very fast. So if you let your guard down, you will have to then backtrack quite a bit. So we want to be very careful how we ease off those and be convinced that it doesn't cause a resurgence again. So it's watching and measuring those metrics and continue to feed those into our modelers too to see how we're doing on the curve and are we making progress. So it's very much data collection, data quality, and the analytics therein. And we have many team members, many groups working on different components. So we're going to get lots of advice and direction on that. And I said these next 2 weeks are an important 2 weeks.
Next question.
Next question comes from Sinead Dougal from Queen's Park Briefing. Please go ahead.
Hi, doctors. I just wanted to ask you about long-term care. You both talked about limiting staff movement between facilities, and it seems like BC has taken this kind of a step at the provincial level. I'm just wondering if this is a directive that's being issued to facilities, and if so, whether it applies to retirement homes as well. And if there's anything more you're looking at doing in this regard to ensure that facilities are trying to, in fact, limit the movement of staff.
So we have made that point aware that if there are staff who are working at multiple sites, they're to inform their employer. If there is an outbreak, then if you're involved as a worker in one facility and that's one of the outbreaks, then the direction is that you're really going to have to step back if you're in quarantine, and you really have to know, the other ones should know, and you're not allowed to work at those other sites because while you're waiting for your testing and to be affirmed whether you're positive or not, you don't want to go and spread to those other institutions. I think as far as other directives, we're looking at other ways to try and handle that, to see how we can handle or limit that movement. As Dr. Yaffe alluded to, one way is, of course, in the cohorting within the facility. Some of our large facilities, you, instead of wandering and being assigned one day on one floor, another floor on a different floor, you stay at the same one for that period of time. So if there is one, you basically have a smaller cohort of staff to look at to see if that was a cause. I think the situation in BC, as I understand, there's a directive, but I have a sense they have had to alter that since that time. So I think you'd have to ask them how that process is going. So it's a challenge that we all face across Canada as we're trying to wrestle and deal with this area of long-term care. And as I said, we're trying to encroach into help and assist with retirement homes as well in a different way.
Follow up?
Yeah, and sorry, if I can just clarify. So let's say, there's a staff member who goes between facilities, but there is an outbreak at one, even though that staff member is not displaying any symptoms. Would they be allowed to then go, to their job in the other facility?
That's where we're asking that they not do that. If they're in an outbreak in one facility, especially if it's been the floor they're on, they are supposed to be being tested and be in isolation at that time until they're cleared or until the outbreak is declared over or ruled out if it's a false alarm. And of course, that's why we say if you're in that situation, you're going to have to be in isolation from all the facilities if you're in more than one, and not be a carrier potential from one institution to the other. So that's our request and that's why if the employers know, they say, well, it says here you also work at LTCX and we're in LTCB. There's an outbreak in X, so you shouldn't be coming into work here until that's clarified in the matter. And so we're trying to, with communication, eliminate that possibility. And of course, due to the asking for the worker to be conscientious of that, very conscientious and very careful, because they wouldn't want to have be the potential source of a spread to another institution and some consequences that lie therein.
Okay, I believe that's the last question. Thank you so much.